schizophrenia. A disorder that affects a person's ability to think, feel, and behave clearly. The exact cause of schizophrenia isn't known, but a combination of genetics, environment, and altered brain chemistry and structure may play a role. Don't get lost in your pain. Know that one day your pain will become your cure. Remember, the world is here for you. On the channel biography there is an email address. You can write and share the world your pain anonymously. What is schizophrenia? Schizophrenia is a mental disorder characterized by continuous or relapsing episodes of psychosis. Major symptoms include hallucinations, typically hearing voices, delusions, and disorganized thinking. Other symptoms include social withdrawal, decreased emotional expression, and apathy. Symptoms typically develop gradually, begin during young adulthood, and in many cases never become resolved. There is no objective diagnostic test. Diagnosis is based on observed behavior, a psychiatric history that includes the person's reported experiences, and reports of others familiar with the person. To be diagnosed with schizophrenia, symptoms and functional impairment need to be present for 6 months or 1 month. Many people with schizophrenia have other mental disorders, especially substance use disorders, depressive disorders, anxiety disorders, and obsessive-compulsive disorder. About 0.3% to 0.7% of people are diagnosed with schizophrenia during their lifetime. In 2017, there were an estimated 1.1 million new cases, and in 2022 a total of 24 million cases globally. Males are more often affected and on average have an earlier onset. The causes of schizophrenia may include genetic and environmental factors. Genetic factors include a variety of common and rare genetic variants. Possible environmental factors include being raised in a city, childhood adversity, cannabis use during adolescence, infections, the ages of a person's mother or father, and poor nutrition during pregnancy. About half of those diagnosed with schizophrenia will have a significant improvement over the long term with no further relapses, and a small proportion of these will recover completely. The other half will have a lifelong impairment. Schizophrenia is characterized by thoughts or experiences that seem out of touch with reality, disorganized speech or behavior, and decreased participation in daily activities. Difficulty with concentration and memory may also be present. In severe cases, people may be admitted to hospitals. Social problems such as long-term unemployment, poverty, homelessness, exploitation, and victimization are commonly correlated with schizophrenia. Compared to the general population, people with schizophrenia have a higher suicide rate, about 5% overall, and more physical health problems, leading to an average decrease in life expectancy by 20 to 28 years. In 2015, an estimated 17,000 deaths were linked to schizophrenia. The mainstay of treatment is antipsychotic medication, along with counseling, job training, and social rehabilitation. Up to a third of people do not respond to initial antipsychotics, in which case clozapine may be used. In a network comparative meta-analysis of 15 antipsychotic drugs, clozapine was significantly more effective than all other drugs, although clozapine's heavily multimodal action may cause more side effects. In situations where doctors judge that there is a risk of harm to self or others, they may impose short involuntary hospitalization. Long-term hospitalization is used on a small number of people with severe schizophrenia. In some countries where supportive services are limited or unavailable, long-term hospital stays are more common. Schizophrenia, mental disorder characterized by significant alterations in perception, thoughts, mood, and behavior. Symptoms are described in terms of positive, negative, and cognitive symptoms. The positive symptoms of schizophrenia are the same for any psychosis and are sometimes referred to as psychotic symptoms. These may be present in any of the different psychoses, and are often transient, making early diagnosis of schizophrenia problematic. Psychosis noted for the first time in a person who was later diagnosed with schizophrenia is referred to as a first episode psychosis. You can't go through life allowing pain to dictate how you behave. I met someone who wants to share the world her pain. Hear from her.
Hi, my name is Tanara. In 2007, I was 23 and attending college, while also working in a restaurant. I was one of the best servers. I didn't even need a notepad to take down people's orders. But at the end of 2008, I started experiencing strange symptoms. I began feeling paranoid. I started seeing things and hearing voices. I didn't want to get dressed or even get out of bed. I didn't understand what was going on. By July of 2009, I was hospitalized. The doctors there thought I had a mood disorder. They thought maybe I was bipolar and put me on a number of medications. But once I got out of the hospital, I stopped taking them. My symptoms were gone, so I assumed I'd be fine. I was no longer taking classes, but later that summer, I was feeling well enough to get a job doing work like painting buildings at a camp. Still, the memory of those strange symptoms lingered in my mind. In April 2010, when the symptoms returned and I began feeling paranoid again, my family convinced me to check myself into a psychiatric hospital. The doctors there still thought I had a mood disorder because I didn't tell them about my paranoia or about suddenly hearing voices in my head. Instead, I would talk to them and just be happy, outgoing, so they thought I was having a manic episode. They started me on some new medication, but when I was discharged 4 months later, I noticed that I was having side effects, like twitching. I wanted to go back to work as a server, but you can't carry trays in a restaurant when you're twitching. So I stopped taking my meds again. I've always had a bubbly, happy personality. I love fashion and R&B music, having cookouts with my family and shopping like any other girl. I love a good discount. I'd always been a peaceful person, but you wouldn't have known that if you'd met me in 2011, just before I was sent to jail after getting into an altercation with a neighbor over a parking spot. My family didn't know what to think, and neither did I. I'd never been in trouble before. They knew it wasn't the real me. The breaking point that turned into a blessing. My grandmother got really sick around Christmas that year. When I saw her in the hospital with all those tubes, I just lost it. I got so hysterical that I had to be escorted out. Soon after that, the altercation with my neighbor happened. My symptoms were acting up and I felt so angry. When I got out of jail, the judge said I had to go to a state psychiatric hospital. I was really nervous, but I talked to a psychiatrist there who made me feel comfortable. For the first time, I opened up about what I was experiencing, the voices, the paranoia. She said, "You were battling schizophrenia." I didn't even know what that meant. She suggested that when I got out of the hospital and off the treatments I was taking there, I try a new treatment for schizophrenia. After weighing the risks and benefits, we both agreed the treatment, given through monthly injections, might help control my symptoms. Meanwhile, I was doing better at the hospital. I made friends and gained insight into my illness. During the week, there were movies, cooking classes and education sessions about my disease, basically, activities to help people like me get back into society. I learned about schizophrenia and what some of my triggers were. All told, I stayed there for 3 months. It was hard, especially when my birthday passed, but I tried to have a little faith, and when doctors told me they were going to send me home in November 2011, that felt like a big triumph. There was light at the end of the tunnel. I started a day rehabilitation program, and also started the new medication, the monthly injections. I was working hard to achieve my care goals by following my treatment plan. My schizophrenia symptoms were under control, and I started feeling better. I regained interest in the things I used to enjoy, like calling my family and going for walks in the park. With my schizophrenia symptoms under control, I felt confident that I was ready to get a job. I began reaching out to different restaurants and got some rejections, but I didn't give up. I ended up getting a position somewhere and I did really well. I built a good relationship with my bosses and co-workers. But I knew I didn't want to be in the restaurant business forever. My dream was to get a professional job in an office, something I could do for the long term. I mentioned that to my caseworker and a nurse at the rehab program, and they told me there happened to be an opening there for a peer support specialist. So I filled out an application, went for an interview, and I got it. My happy, beautiful life today. That was 3 years ago. I started out doing wellness checks on patients and taking them to doctor's appointments and grocery shopping. After 6 months on the job, I was ready to get certified and take on more responsibility. I enrolled in a week-long course about the peer support profession and ended up with a 99% on my certification exam. Now I'm helping other people living with schizophrenia set and execute goals that they never thought possible, and helping ensure that they have the same opportunities that I did. Things looked bad for so long. I thought I'd be a server for the rest of my life. I kept telling myself I needed to have patience, but patience was a hard thing to have. I also worried that I'd never be in a relationship. But I've since met someone, and my boyfriend and I moved in together September 2012. I've done a lot of soul searching to get to this place. Now that I've come through that dark time, I feel humbled and grateful for everyone who supports me, like my family and coworkers. As for the future, I want to broaden my advocacy work and learn about more ways to support the people I serve. I also want to be able to travel, and, like many women, get engaged and married down the line. My goal is to help other patients get their confidence back. If you don't have that confidence, you won't ever feel that you deserve to be happy. I know because I lost my confidence for a while. I try to let them know it's possible to have the happy and beautiful life you had before the diagnosis. I will never forget what I went through, or what it took for me to get here. I don't take any of it for granted. I want to be a role model for other people with schizophrenia. I consider myself an advocate for people who don't have a voice. I honestly understand how patients feel about wanting to be better, how difficult it can be to figure out medication. That was my pain, it ruined me, but at the end I win. Never give up on yourself. Talk to people. Get helps. Goodbye.
Signs and symptoms of schizophrenia. 1. Positive symptoms. Positive symptoms are those symptoms that are not normally experienced, but are present in people during a psychotic episode in schizophrenia. They include delusions, hallucinations, and disorganized thoughts and speech, typically regarded as manifestations of psychosis. Hallucinations occur at some point in the lifetimes of 80% of those with schizophrenia and most commonly involve the sense of hearing, most often hearing voices, but can sometimes involve any of the other senses of taste, sight, smell, and touch. The frequency of hallucinations involving multiple senses is double the rate of those involving only one sense. They are also typically related to the content of the delusional theme. Delusions are bizarre or persecutory in nature. Distortions of self-experience, such as feeling as if one's thoughts or feelings are not really one's own, to believing that thoughts are being inserted into one's mind, sometimes termed passivity phenomena, are also common. Thought disorders can include thought blocking and disorganized speech. Positive symptoms generally respond well to medication, and become reduced over the course of the illness, perhaps related to the age-related decline in dopamine activity. Two. Negative symptoms. Negative symptoms are deficits of normal emotional responses, or of other thought processes. The 5 recognized domains of negative symptoms are: blunted affect, showing flat expressions or little emotion; alogia, or poverty of speech; anhedonia, an inability to feel pleasure; asociality, the lack of desire to form relationships; and avolition, a lack of motivation and apathy. Avolition and anhedonia are seen as motivational deficits resulting from impaired reward processing. Reward is the main driver of motivation, and this is mostly mediated by dopamine. It has been suggested that negative symptoms are multidimensional, and they have been categorized into 2 subdomains of apathy or lack of motivation, and diminished expression. Apathy includes avolition, anhedonia, and social withdrawal. Diminished expression includes blunt affect and alogia. Sometimes diminished expression is treated as both verbal and non-verbal. Apathy accounts for around 50% of the most often found negative symptoms and affects functional outcome and subsequent quality of life. Apathy is related to disrupted cognitive processing affecting memory and planning, including goal-directed behavior. The 2 subdomains have suggested a need for separate treatment approaches. A lack of distress relating to a reduced experience of depression and anxiety is another noted negative symptom. A distinction is often made between those negative symptoms that are inherent to schizophrenia, termed primary, and those that result from positive symptoms, from the side effects of antipsychotics, substance use disorder, and social deprivation, termed secondary negative symptoms. Negative symptoms are less responsive to medication and are most difficult to treat. However, if properly assessed, secondary negative symptoms are amenable to treatment. Causes of schizophrenia. The causes of schizophrenia are unknown, and a number of models have been put forward to explain the link between altered brain function and schizophrenia. The prevailing model of schizophrenia is that of a neurodevelopmentally disorder, and the underlying changes that occur before symptoms become evident are seen as arising from the interaction between genes and the environment. Extensive studies support this model. Maternal infections, malnutrition and complications during pregnancy and childbirth are known risk factors for the development of schizophrenia, which usually emerges between the ages of 18 and 25, a period that overlaps with certain stages of neurodevelopment. Gene-environment interactions led to deficits in the neural circuitry that affect sensory and cognitive functions. Prevention of schizophrenia. Prevention of schizophrenia is difficult as there are no reliable markers for the later development of the disorder. It is unclear as of 2011 whether treating patients in the prodrome phase of schizophrenia provides benefits. There is a discrepancy between the growth in the implementation of early intervention programs for psychosis and the underlying empirical evidence. There is some evidence as of 2009 that early intervention in those with first episode psychosis may improve short-term outcomes, but there is little benefit from these measures after 5 years. Cognitive behavioral therapy may reduce the risk of psychosis in those at high risk after a year and is recommended in this group by the National Institute for Health and Care Excellence, NICE. Another preventive measure is to avoid drugs that have been associated with development of the disorder, including cannabis, cocaine, and amphetamines. Antipsychotics are prescribed following a first episode psychosis, and following remission, a preventive maintenance use is continued to avoid relapse. However, it is recognized that some people do recover following a single episode and that long-term use of antipsychotics will not be needed, but there is no way of identifying this group. A 2015 Cochrane review found unclear evidence of benefit from brain stimulation techniques to treat the positive symptoms of schizophrenia, in particular auditory verbal hallucinations. Most studies focus on transcranial direct current stimulation and repetitive transcranial magnetic stimulation. Techniques based on focused ultrasound for deep brain stimulation could provide insight for the treatment of auditory verbal hallucinations. The study of potential biomarkers that would help in diagnosis and treatment of schizophrenia is an active area of research as of 2020. Possible biomarkers include markers of inflammation, neuroimaging, brain-derived neurotrophic factor and speech analysis. Some markers such as C-reactive protein are useful in detecting levels of inflammation implicated in some psychiatric disorders, but they are not disorder-specific. Other inflammatory cytokines are found to be elevated in first episode psychosis and acute relapse that are normalized after treatment with antipsychotics, and these may be considered as state markers. Deficits in sleep spindles in schizophrenia may serve as a marker of an impaired thalamocortical circuit, and a mechanism for memory impairment. MicroRNAs are highly influential in early neuronal development, and their disruption is implicated in several CNS disorders. Circulating microRNAs, cmRNAs, are found in body fluids such as blood and cerebrospinal fluid, and changes in their levels are seen to relate to changes in microRNA levels in specific regions of brain tissue. These studies suggest that cmRNAs have the potential to be early and accurate biomarkers in a number of disorders including schizophrenia. A soul that carries empathy is a soul that has survived enormous pain. Thanks for watching. Don't forget to like and subscribe. Catch you later.